Good morning, everyone. Myself, Dr. Abdul Samad, pediatric resident from AIMS Jodhpur. So today we'll be discussing a very interesting and very much feared and ignored topic, that is medico-legal cases in clinical practice. Coming to the objectives of the class, we'll be discussing the various medico-legal cases, the few of the case scenarios which we see in our day-to-day practice, the documentation in medico-legal cases, and few slides about the POXO Act, the broad death protocol, and then about the medical certification of cause of death, which is must know if you are practicing in emergency or ICU setting. This slide shows like how doctors are being charged for various medico legal aspects. So it is important to know the documentation what need to be done in case of medico legal cases to avoid such penalties. This is a research article which shows the characteristics of medico-legal cases and errors in medico-legal reports at a teaching hospital in Saudi Arabia. The types of error which the attending doctor did was they have not mentioned the time of admission in around all the cases, and the designation of the physician was not written in almost 99.5% cases, and the level of consciousness status was not written in 98.8% of the cases. So this shows that what are the mistakes doctors do and what we need to stress upon in case of medical legal cases to avoid the charges. Coming to the medical legal case per se, the definition, it is a case of injury or ailment where attending doctor after taking history and clinical examination thinks that some investigation by law enforcing agencies are essential so as to fix the responsibility regarding the case and penalize as per the existing law of land. The various medical legal cases, the examples of various medical legal cases are the domestic violence or child abuse case, the road traffic accidents, cases of trauma with suspicion of foul play, sexual offenses, broad death cases with improper history creating suspicion of an offense. Suspected homicides, suicides, suspected or evident poisonings, burn injuries or electrocution cases, animal attack or snake bite cases where we should consider making an MLC. Any unconscious case where the cause of it is not clear or not natural. This is a case scenario which we often see in our day-to-day practice. This is a 3-year-old boy brought to pediatric acute care area with alleged history of snake bite over the forehead at 3:30 p.m. on 5th October while playing at his home, following which he developed swelling over right side and over right eye and right side of the face. So we have to know that whether it is an MLC or not. As it is a snake bite case, it is an MLC because snake can be used as an homicidal also, and there is compensation by the government of India, and for documentation purpose, uh, it is an MLC. This is a triage sheet of the same child where the resident doctor has filled the triage sheet, but what he missed is he has not mentioned the not put the stamp on the triage sheet, the MLC stamp which has to be there in case of medical legal cases, and he has not taken a written referral to the forensic medicine to make an MLC, and there was no sign of the treating doctor name, designation, and time and date. So these are the deficiencies which were there in the triage form, which we should try to avoid. This is a real life case where husband used cobra to kill his wife. So snake bites can also be used as homicides. and the compensation by the government of India in cases of snake bite, like if a patient dies of snake bite, then the family gets rupees 2 lakh as compensation, and if there is any bodily harm, then the patient will get around 50,000. This is another case. A 15-year-old boy brought to pediatric acute care area with alleged history of road traffic accident. Child was riding bike, got hit to cow accidentally, followed by loss of consciousness for 5 minutes. On examination, vitals were stable, GCS was 15/15, systemic examination was within normal limits. NCCT had showed mild bleed in the right corpus callosum. Child was admitted later on in pediatric neurosurgery ward. Is it an MLC? Like as a 15-year-old boy, he should not ride the bike. So it will be an MLC. This is a trash sheet of the child where the resident has mentioned it is an MLC, and he has put the stamp on the trash sheet also, but he has not written the referral to the forensic team to make an MLC, and there is no sign of the treating doctor or the name and designation. Here the forensic expert has put a MLC refusal done. So what is an MLC refusal? It is done in cases where the attender of the child doesn't want to make an to file a case, and the treating doctor thinks that there is no foul play. So MLC refusal is made, and it is also informed to police. Coming to the relation of doctor and MLCs, every doctor under law bound by a contract to serve its patient and cannot refuse treatment. Medical legal case examination and reporting is one of the legal responsibility of all doctors working in a hospital. Why to manage an MLC? MLCs are just as non-MLC cases, sick, and the doctor is duty bound to treat as well as document the details, as it is a crucial piece of evidence which will be used later on in the court of law if required. The responsibility to label any case as an MLC rests solely with the attending medical practitioner. Even if the attenders are not willing to make an MLC, it is solely depend on the attending medical practitioner to make an MLC if he feels so. If he suspects any foul play, then he should make an MLC. Every medical practitioner at some point of time in his career would have encountered MLCs. Many a practitioner are usually apprehensive in dealing with these cases, as they feel MLC means entangling in police cases, indefinite hours to be spent in the court, facing unrelenting defense counsels. Because of this fear factor, many a practitioners try to manipulate the MLCs as non-MLC cases and try to avoid such cases. The best way to deal with these cases is to understand them clearly, analyze them thoroughly, and then act accordingly. Coming to the differences between medical legal cases and non-medical legal cases. In case of MLC, information to police is must, whereas in non-MLC cases, no such information is given to police. The reports which we make, the medical legal report, it should be made in duplicate, and one copy is handed over to the police and his signatures taken on doctor's copy. The other copy is written with the doctor in a medical legal register, which he may have to produce before court. Both copies of medical legal report must be marked medical legal case in bold, whereas no duplicate copies are made in non-MLC cases, and no such mark of MLC will be put on non-MLC cases. The MLC protocol followed at our hospital is whenever a child comes to pediatric acute care area, the duty JR or SR, if thinks that MLC should be done, then after giving emergency treatment, he intimates the police and he mentions the name, designation, and bed number on the trial sheet of the patient, and then he takes a forensic medicine referral for MLC, and he document the detail and relevant history and examination findings, including the injuries and bite marks, etc., which are present. If child had been taken to other hospital, then the forensic JR or SR will make a referral and not make a second MLC. So whenever a child who has already been taken to local hospital and their MLC has been done, then there is no need to make second MLC unless it is specifically asked by the police to make a second MLC. So after you have informed the forensic expert, the forensic team will make an MLC and will put the MLC stamp on the patient's documents. If the attendants are not willing for filing a case, then if indicated, the forensic team will take informed refusal from the attendants and inform the police. After making an MLC and putting the MLC stamp on patient document, the forensic expert makes medico-legal report and keeps two copies of it. One is given to the police and the other one is kept in the medico-legal register. In our hospital, it is done by the forensic department, the medico-legal report, whereas in other hospitals, it is the duty of the casualty doctor who is there to make a medico-legal report. And whenever a case of MLC is disposed, either discharge or patient taking LAMA, we have to inform the police, and all the absconded cases are supposed to be informed to the police. And in case if a patient dies, then we have to inform the police and send the body to mortuary for postmortem examination. Coming to the general guidelines which we should be keeping in mind in cases of MLC. All the MLCs have to be attended round the clock without delay. Consent of the patient or relatives is not required for labeling a case as MLC. In fact, even the patient is stressing that he does not want an MLC, it should still be made if the treating doctor thinks so. If there is a delay in labeling a case as MLC, then later on it can be labeled at any later on date and time, but not before the death of the patient. Treatment in serious cases must take precedence over completion of the documentation, that is a medical legal report. The consent for treatment is implied in emergency cases. The private practitioners have to make an MLC. Practice of sending the patients to government hospitals for getting registered at MLC is wrong. If the patient dies on the way to government hospital, the private practitioner is sued under section of 304A IPC, that is the Rash and Negligent Act. If a MLC case has been referred to another hospital, the second hospital does not make the new MLC, but notes the MLC referral. Second MLC is made only in cases where special request is made by the police. The documentation which we should keep in mind in case of MLCs, coming to the consent for examination. If a patient is arrested by police and is brought to your hospital, then you should not take the consent as the patient is under police custody. And if patient himself comes there to you, then you have to take the consent. The implied consent is only for general examination. You have to take the express consent, and you have to note two identification marks of the patient, general condition of the patient, including the mental status, whether the patient is in sound mind to give any statement, and the type of injury. All the injuries, however insignificant they may appear, should be recorded. Proper, adequate, and complete documentation is necessary in all medical legal work. Legally, only those injuries are present that have been recorded. Whatever has not been recorded was not present. So it is the duty of the attending medical practitioner to mention all the injuries which are there. If he has forgotten to mention any injury, then it will be considered as not present. The size, shape, and direction of each injury should be mentioned in detail and the part on which it is there, the body part on which it is there, it should be mentioned. The age of each injury should be mentioned. What on examination, what you feel. Like in cases of battered baby syndrome, the injuries are at various stages of healing. The nature of each injury, including the simple, whether they are simple injury or the grievous hurt, that should be mentioned, as the punishment for a simple and grievous hurt is different. And by what weapon it is inflicted, whether it is a sharp-edged or blunt weapon, that should be mentioned, and whether the weapon was dangerous or not, as the punishment is different for injury caused by a dangerous weapon. This is a medical legal report which is there in our hospital. Uh, it has three parts. This is a preliminary part. This is a body where the type of injury and site of injury, the age of injury, the weapon used, that the forensic expert writes, and finally he gives his opinion about the injuries. This is a medical legal X-ray form. It has a X-ray plate number also. So whenever a forensic expert thinks that X-ray is required, then you have to fill this form, and you have to mention the X-ray plate number also, which was used, because that X-ray plate will also go to the court of law if required. This is the medical legal refusal or referral register, which is there in our hospital. Here, even if we are making an MLC refusal, like the patient attenders are not willing to file a case, and the doctor thinks that MLC refusal can be taken, then the doctor takes the informed refusal and takes the signature and thumb impression of the patient and the guardian. Coming to the medical legal report or injury report, a good medical legal report should be clear, concise, complete, objective, and legible. Relevant negative findings must be included. For example, if a patient tells that he has an injury over the right thumb, but on examination you didn't find any injury, so you have to write in that there was no injury on the right thumb as described by the patient, and you have to avoid the technical terms and abbreviations must be avoided. Description of evidence preserved should be mentioned along with the doctor's counsel. They have to be preserved, and all the medical legal reports, two copies of them are made. One is given to the police and other one kept in the medical legal register. All the MLCs should be informed to the police under section 313 and under section 39 of CRPC, irrespective of the patient's wish. If doctor does not inform, then he is sued under section 176 and 202 of IPC and does not hand over the relevant evidence to police. Then doctor may be charged for causing disappearance of evidence under section 201 of IPC. If you are a doctor in a government setup, then you have to inform to the police officer posted in the government hospital, who passes this information to the local police where the crime was committed. Private practitioners must inform the local police station. The doctor should ask the police official on phone the daily diary number and should record it in his injury report. The date and time of making the call, also the name, designation, and number of the police official informed should be noted. Preservation of medical legal evidence. All the medical legal evidence, whether they are the clothing, the contents of the gastric lavage, or any specific thing that you think it can be useful in the court of law as an evidence, should be preserved and subsequently sent or handed over to the investigating authorities for forensic examination. All evidence will be identified, sealed, and labeled properly. Once collected, loss or destruction of evidence is a punishable offense under section 201 of IPC, which we have seen in the last slide. Original copies of all the medical legal documents will be produced whenever asked for in a court of law, and all the original copies of medical legal documents must be preserved until the finalization of case in the court of law. Here is a child, 16-year-old girl, brought to our pediatric acute care area with complaint of amenorrhea for 5 months. At arrival, child was in active seizures. On examination, there was hypertension. And you did a UPT, which came to be positive. So this is a case of eclampsia, and as the child is 16-year-old, it is a case of child sexual abuse. So we have to intimate the police under the section under the POXO Act. The POXO Act is the protection of children from sexual offences, which came into force on 14 November 2012. It provides protection from the offences of sexual assault, sexual harassment, and pornography, and provide establishment of special courts for trial of such sexual offences. The act is gender neutral, that it includes both girls and boys. The various offences covered under the act and the punishment given were: in case of sexual assault, the punishment is minimum of 5 years of imprisonment and maximum of 7 years along with fine. In case of aggravated sexual assault, which is sexual assault by a police officer or the armed force or staff of a hospital or jail, in such cases the imprisonment is for minimum of 7 years and maximum of life imprisonment along with fine. Whenever a child sexual abuse case comes to your hospital, your duty is to do a medical examination in respect of whom any offense has been committed. Even if the child or the patient doesn't have any document or the FIR to examine the child, you still have to examine the child under the section 164A of CRPC. And in case the victim is a girl child, the medical examination should be conducted by a woman doctor. The medical examination shall be conducted in the presence of the parent of the child or any other person in whom the child reposes a trust. If there is no such person, like the child's parents are not present, or the person in whom child trust is not there, then the medical examination shall be conducted in the presence of a woman nominated by the head of the medical institution. And in whenever an officer of the Special Juvenile Police Unit or the local police receives information under Section 19 of the POXO Act that an offense under the Act has been committed and is satisfied that the child against whom an offense has been committed is in need of urgent medical care and protection, he shall, as soon as possible but not later than 24 hours of receiving such information, arrange for emergency medical care. And emergency medical care shall be rendered in such a manner as to protect the privacy of the child. Coming to the various laws which are related to MLCs, under section 39 of CRPC, it is the duty of the doctor to give information about certain cases to the police, and the section 176 of IPC tells about gives a punishment for omission of giving notice to the public servant by person legally bound to give it. And section 201 IPC gives punishment for causing disappearance of evidence or giving false information. Coming to broad death cases, in our day-to-day practice, we see so many broad death cases brought to our emergency. We have to make MLCs in all the broad death cases. And whenever a broad death case comes, firstly, vigorous attempts must be made to resuscitate the patient. After all attempts have failed and patient is declared dead, then we have to follow certain steps, like we have to verify the identity of the deceased using available documents, identification tags, and accompanying individuals. We have to immediately inform the local police that a broad death case is there in our hospital. We have to do a thorough medical examination to identify any visible injuries or signs of foul play and document the findings, including the descriptions of injuries, the rigor mortis or lividity, which tells about the time at what time the death has happened. And we have to preserve any potential evidence such as clothing, personal belongings, or trace materials to identify the patient. And we have to cooperate with the police and forensic authorities throughout the investigation process. In the cause of death, against the column of cause of death, one should write not known broad death in case of broad death if the cause is not known. Many doctors mention on record that patient came gasping and they have diagnosed cause of death, though cause is broad death cases. So we should avoid such things and we should not comment on the cause of death unless we are sure about it. And we have to write not known broad death if the cause of death is not clear. Coming to few points about the medical certification of cause of death. It is the duty of the doctor to give, after a patient dies in his hospital, the cause of death certificate. It is a classification of causes of death according to sequence and quantum of their contribution to death. It has two portions, 1 and 2. In 1 there are three parts, 1A, 1B and 1C. And 2 it is the contributory cause. In 1A we have to write the immediate cause which has directly led to the death. And in 1B we have to write the intermediate cause which has led to immediate cause which finally led to the death of the patient. And in 1C we have to write the underlying cause. We'll see with the following examples how to write the cause of death in various situations. Like here is a 16-year-old boy, known case of cyanotic CHD with cerebral infarction with right hemiparesis. Child falls while walking, leading to right femur fracture, for which he underwent surgery. Around 24 hours after the surgery, child developed sudden onset breathing difficulty. CT angio showed filling defect in the main pulmonary artery, which suggests that there is pulmonary embolus. So, in 1A of the medical certification of cause of death, we have to write pulmonary embolism, as it is the immediate cause which led to the death of the patient. And in 1B, we have to write the surgery, post-surgery fat embolism leading to pulmonary embolism causing death of the patient. And 1C, which is the underlying cause, is a fall or cerebral infarction causing the right hemiparesis leading to fall of the patient. Coming to another case, here is a 15-year-old boy, case of dengue with MODS, stage 3 AKI with encephalitis with catecholamine resistant septic shock with refractory hyperkalemia with refractory ventricular tachycardia, died in your PICU. So in this case, the 1A will be refractory ventricular tachycardia as it has directly led to death of the patient. And the cause of refractory ventricular tachycardia is refractory hyperkalemia with stage 3 AKI, which should be mentioned in 1B. And in 1C, which is the underlying cause, is dengue. Because of dengue, there was stage 3 AKI, which led to refractory hyperkalemia, and because of which there is refractory ventricular tachycardia leading to death of the patient. Here is another case, a 16-year-old boy brought to the hospital in unconscious state with alleged history of consumption of organophosphorus compound 6 hours back after getting scolded by his father. Child was in hypotensive shock. On examination, pupils were pinpoint and fasciculations were present. After 2 hours, patient developed respiratory paralysis and pulmonary edema. And patient was resuscitated but died after 4 hours of admission. So in this case, the 1A will be the respiratory paralysis and the pulmonary edema, which has directly led to the death of the patient. And in 1B, it is because of the organophosphorus compounds which has led to respiratory paralysis. So in 1A, the immediate cause will be 1A, that is the immediate cause, will be respiratory paralysis and pulmonary edema, and 1B will be OP poisoning. This is a medical certificate of cause of death, which is Form 4. Like in cases of institutional deaths, we have to fill the Form 4, whereas in non-institutional deaths, we have to fill Form 4A. Here it has two parts, which we have seen already in the previous slide. This is the cause of death, 1A, which is the immediate cause. It is the state of the disease, injury or complication which caused the death and not the mode of dying. So in 1A, we should not write respiratory failure or cardiac arrest or heart failure. And in 1B, it is the antecedent cause, the intermediate cause, and 1C is the underlying cause. And here we have to write the manner of death. In the previous case, we saw the OP poisoning. So in that case, the manner of death will be suicide. And this is the detachable portion of the cause of death certificate, which has to be handed over to the attenders, which they will submit in the municipality to get the death certificate. And the other forms which we have to fill in case of a death happened in hospital is form number 2, which is the death report, and the form number 6, which is the death certificate. It is filled by the municipal officers and not the doctors. We often see doctors telling to after a patient dies, fill DC, but it is a MCCD, which is a medical certificate of cause of death, which we have to fill, and not the DC. That is the death certificate is filled by the municipal officers. The take home message, we have to do proper documentation and we have to keep medical legal records. Whenever there is any requirement, we have to issue those records. And these are my references for the class.